Legal responsibilities and scope of practice. This is general information and not used for professional clinical legal advice. We strive to keep our information as accurate and timely, but make no promises and guarantees. It works for your local unique situation. Just as an introduction, midwives must provide safe, ethical care within their legal boundaries on a national and a state local level. We are accountable for those actions. We operate within our scope of practice, our expertise and training under those professional regulations. I think this is really important to get to the basics of because too many times I hear midwives like, well, all my colleagues do it that way, or I will do birth center consulting, and they'll be like, well, the regulations say to do this, but all the other birth centers in our state do it this way. And we have to be individually accountable to the laws and the training we have and what our local area dictates. If there are no state regulations, they're going to reference national certifications, national guidelines, common standards within a region. So if there's neighboring states, what's the community standards? There's going to be reference points and benchmarks they use when determining what is your scope of practice. So midwives have a duty to protect their patients, to protect their families, to be able to keep up with standards of care, get the education and training, practice within the scope of their local area. What I can do in Alaska, what I can do in Mississippi, what I can do in Michigan, Texas, all over the United States and all over the world are different. So I've been a traveling midwife since 2016, and every location I go to has a different scope, has a different standards, has regulations for prescription authority, for even the hospitals. Like, there's that next level of local standards. The hospital privileges may be more conservative. They can't be less conservative. I'm going to give you some examples as we go throughout this process of situations where the scope of practice for midwifery has been pushed, has been violated by patients, by employers, by the midwives themselves. We have a duty of care. We have to provide professional, safe care throughout pregnancy, birth, postpartum. If we don't meet those standards, we're going to have complaints, we're going to have safety, we're going to have bad outcomes, and it's going to lead to malpractice claims, negligence, disciplinary actions, potentially losing licenses, potentially losing everything. I can tell you story after story of midwives that were doing really, really well financially, life, but they practiced outside of the scope of that local area, and a bad outcome happened and they lost everything. Breech presentation in birth centers where the state doesn't recognize midwives can do twins and breech. There are a couple states they can, but most states, those are considered high risk based on ACOG, the American College of Obstetricians and Gynecology. So even though we're nurse midwives, if there isn't a position or a defense, a lot of times the legal system will go against what our obstetricians think that a midwife should do. So we always have to be very careful. What is our definition of low risk? What is our definition of moderate risk where its collaboration is in place? What's our definition of high risk and needs to be transferred to an obstetrician, a maternal fetal medicine, a pediatrician? We have to have those policies and protocols in place. I can give you examples of currently I am traveling in the Virgin Islands, and the midwives here, there's no prescription authority, there's supervisory. You're considered a higher level of a labor and delivery nurse versus a care provider in this culture, in this system. And so you can't all of a sudden be writing prescriptions, acting independently when the scope and the culture and the norms of that area do not dictate it. When I was a new graduate in Alaska, it was one of the most autonomous places for a midwife to practice. There were nurses and nurse practitioners and PAs and midwives that had their own businesses, had complete autonomy, had independent hospital privileges. It was a different culture. It was a different situation. So Indian health reservations versus federally qualified health centers versus the private sector. A private a hospital or a community-owned hospital, they're all going to have different standards of how you can practice. When you do your home birth center practice, that doesn't mean you get to do whatever you want. You still have to put into place policies, protocols, guidelines that fit your national, state, local standards, and if they don't exist, you probably should be a little more conservative than the average midwife. Informed consent is a really important topic. It's near and dear to my heart when it comes to midwifery and pregnant women. A lot of times during labor, it's in a very vulnerable place. They're not having a right state of mind. They will ask you to cut off your arm to make the pain go away, and that doesn't mean we do that. So I did my thesis in graduate school about informed consent of epidurals because as a labor and delivery nurse for many years before that, it would be very frustrating for me, the biases or the not truth. Oh, epidurals are so safe. Anesthesiologists would just come in quickly and go over the high levels, and you'd have complications. You'd have bad outcomes. You'd have spinal headaches. You'd have long-term chronic pain. You'd have a lot of women that just thought it was so safe and perfect and disappointed with their experiences. And so we have to empower our families, our patients to the next level to really make the decisions for themselves and make sure we're having the education when they're in the right state of mind. Labor is not the time to be doing informed consent. We should have had it and talked about the options, the tools in their toolkit before the labor had occurred. So especially in obstetrics, it's a high litigation space. Document everything. Have your clients sign, yes, we went over this. They watched a video. We did have a discussion for 20 minutes. These are exactly the things we talked about. Document. The more defense you can give that proves the patient understood and made the decision wholeheartedly themselves in the right state of mind, the better chance you have to defend yourself of, yes, we want individualized, personalized care and empowerment of patients, but we have to be careful of our own biases, the situation, how rushed it is. Are we truly giving informed care and pushing them one way or the other, especially when you're doing home births? And I've had situations where I realized I was in a sticky situation because they wanted to do a vaginal birth after C-section, and when they ruptured for days and days, they're not contracting, we're worried about signs of infection, and you're like, I want to go to the hospital, I want to get further evaluated, and the patient says, I'd rather die than go to the hospital. You've got a problem, you've got a challenge. Maybe that patient wasn't the best candidate for a home birth based on her trauma and her personal biases and her extreme fear of the healthcare system. We needed to resolve that before we got into this tough situation. So that's why informed consent is so important for midwives, for maternity care, for our patient advocacy. Confidentiality and privacy, we want to be able to, HIPAA is a huge deal, and I see midwives and community-based practices and birth workers violating HIPAA often. They don't do it on purpose, they just aren't educated and don't know. You can't text medical information, even though it's convenient and we love our clients, we have a personalized relationship in the community setting. HIPAA is a little, I wouldn't say easier to follow, but there's clear expectations in the hospital setting because there's a lot of policies, there's a lot of check and balance systems, there's a whole compliance HIPAA department to make sure everybody's doing what they're supposed to be doing. They'll send test emails, they'll walk around departments to see if there's patient information sitting on a desk in public, are people signing out of the computers. When you're in the community setting, we have to be a lot more accountability and put our own check and balances in place because there isn't a big department, a big resource pool implementing that for us. So emails, you have to do HIPAA compliant messaging system through charting systems. I get it if you're the Amish and paper, but you're also not going to be worrying about the technology side of emails and texts from them too. So you got to be careful with your paper charts and that they're in a locked, secure space in your vehicle. They can't just sit in a bag even though your car is locked, your car gets broken into, you have to have a lot of check and balances of protecting the personal information. And when you're a small community midwife, you tend to know everybody. So you can't talk about births, you can't talk about their stories, you can't talk about their situation, even though it's their sister and you've taken care of all these people and they'll learn it from somebody else. You can't be part of the community gossip and updates of your patients. You have to protect their privacy. If they want to share it, if they hear it from somebody else, that's okay. But we have to be very careful. We're not their friends. We're their midwives, their healthcare providers. Documentation is something near and dear to my heart. As midwives, we I see a difference between the midwives that have been labor and delivery nurses and the midwives that practice in the hospital and the midwives that have always been community-based midwives. Because the medical terminology, the telling a story, being able to think in a mindset that in many states up to 18, 21 years, this is my legal defense to tell my side of the situation if there is litigation, if there is a complaint. Yes, documentation is used to communicate with a team, to tell the care management, but I look at it as the perspective of I need to, if someone reads this later, they know what happened in labor, they can see the picture versus it's very scattered and there's gaps, and those gaps, if it's not charted, it's not done. So I think we need to get scripts in place with our charting systems, because I don't want you writing a book every single time you see them, but 90% of your care is going to be a similar style, a similar way during pregnancy and birth. And you can make educational scripts. You can make tools and templates for your informed consent. You can make plan of cares for diabetes, hypertension, for common management conditions, and then you just customize it based on that individual plan made with that client, patient you're serving. So, especially during labor, it's hard because a lot's happening. You want to chart real time, you want to take care of them. So, that's why there's a lot of great ways to do paper, to do electronic, to accelerate and streamline your charting process so it doesn't take so much time. You're not staying hours and hours after your shift. You're not tired and exhausted and trying to tell a story later in an out of hospital birth when it's not as accurate. The real time is the best. So there's little ways you can do that to make flows, to get into habits, using appropriate medical acronyms. I see a lot of people will use measurements and use terms, especially in the out of hospital setting, because it's what their apprentice taught them, versus they took the time to be like, I'm going to be communicating with the medical system. I'm going to be in a court system being defending myself. I need to look credible and professional, and I need to communicate consistently, because this word to me doesn't mean the same thing to everybody else if it's a unique one. I've seen so many, particularly community-based midwifery documentations. They're telling about their prayer and they're telling about the baby's name and the emotions of the situation, and that's not what the point of the documentation is. The point of the documentation, this is normal. What were the signs of normal? This is concerning. What made it concerning? What were you doing about it? What were your interventions? What was your follow-up plan? Did you resolve the situation? What are the concerns happening? What was the education? Are things progressing normal? If they're not progressing normal, what are you doing about it? What conversations you're having with the family? You have to be able to tell your story to defend yourself to hospital transfers, to the medical system, to the legal system that's set up for this medical mindset of birth, whether it's right or wrong. Referrals and collaborations with other healthcare providers. I think as midwives, depending on where you practice, some places are more midwifery friendly and some places are very hostile to midwives. So I'm not saying it's right or wrong, but you have to do the best of your ability in your local area. How do you collaborate with the doctors, with the nurse practitioners, with the chiropractors, with the naturopaths, with the other midwives in the area? You're sick, you need some backup support, the baby's not doing well, you need to talk to the pediatrician, there's some challenges during pregnancy, there was some abnormal results on her ultrasound. Even if you're an independent midwife, you still have to set up formal and informal collaboration relationships with hospitals for labs and ultrasounds and testing and care providers. When you're an employed midwife, it's so much easier because you're part of the establishment. You're employed, you're part of the inside club. It's way easier to do referrals and a collaboration, and I get that and I understand the differences. But we have to set them up. If you are employed, usually the healthcare system, the administration team sets up those collaborations for you. But sometimes not. If you're a private practice, even if you're employed by an obstetrician, you still have to set up community referrals and specialty networking and build relationships in your community, because our care is phenomenal, not just because of what we do, but because of the network we set up of smooth transitions for our patients to one specialist compared to another. Handling emergencies. I can't stress enough how many midwives, yes, we do our BLS and our NRP and our mandatory certifications and our CEUs required to be midwife maintenance, but I rarely see midwives hospital, birth center, home that do consistent regular peer reviews, skills and drills on a monthly, quarterly basis. Like, we tend to read about it and then do some extensive drills because now there was a bad outcome and we have to learn from it. I would rather our system be much more proactive than reactive. And I get it. Things are busy, overwhelmed. Most of the time birth is normal, but we should be able to know how to do postpartum hemorrhages, shoulder dystocias, prolapse cord, newborn resuscitations, non-reassuring heart tones like the back of our hands. It should be instinctually our entire team. It doesn't matter how amazing the midwife is. You have to practice this with your team. I give the example to community-based midwives all the time. Newborn resuscitations are the highest litigation component for transfers for outcomes because this baby can't advocate for itself. It needs oxygen. Airway is the number one thing to survive and have great outcomes. You can be phenomenal at newborn resuscitation, but if EMS comes and it's the typical EMS where they don't have NRP, they have the minimal training of babies, and you don't go and you continue the newborn resuscitation, and there's deoxygenation and bad outcomes, it's a bad outcome reflecting on you, and it's a bad outcome for the baby. So we have to have plans and protocols that we do skills and drills with our local EMS services, our hospitals, so that we can have a smooth transition every step of the way. I understand it's a lot harder with home birth practices. Birth centers have a concrete location. Their supplies are consistently in one place. EMS always knows they're going to go to that same place. But we have to improve these relationships. When we talked in the last slide about collaboration, EMS is a collaboration. I rarely see community-based midwives work on improving that relationship with their local EMS services. And I think that's a huge opportunity to improve their education. They barely get anything with moms and babies part of their training. It's not part of their required continuing CEUs. They fear just as much as the hospital ER does pregnancy, labor, and birth. And so we have to, as midwives, not just training ourselves, but training our community, training our collaborations, we have to be more proactive of keeping up with the evidence, getting our hands and our brain at 2 in the morning when we're tired to instinctually kick in and switch when those emergencies occur. Compliance with state and national law. You really want to make sure you're moving to a new area. Even if you've lived there forever, laws change, things, guidelines, bills get passed, standards, evidence improves, compliance certification standards change. There may be more taken out, added. There's things that are part of core competencies, and then there's advanced practice things, and you need to have the proof of your training, your certification, your sign-offs of competencies if it's an advanced practice thing to prove you're safe and qualified. So I go back to the example of breech presentation. Most, even hospital settings, few obstetricians don't do breech anymore. Few facilities, I've seen Indian health reservations where the midwives can do breech, but there's only a couple states for community-based side that actually recognize, Texas and a couple others, to do breech if you've got the right training and certification. Breech Without Borders is phenomenal, and get that training, because we make the assumption of like, oh, I don't have to worry about it because our hospital doesn't do breech presentation. You still have to get the training of those emergency situations. No prenatal care comes in breech presentation. You have to be able to take care of them in the hospital setting until the obstetrician arrives. In the community-based setting, that baby flips overnight. And even if you weren't planning and your scope and standards doesn't have planned breech deliveries, they're going to happen to you when they're not planned. I can promise that for you. So you need to have the skills and training and the defense to say, okay, it's not part of my scope and practice to accept planned breech deliveries. She was head down based on Leopold's on our last prenatal visit. I came to her house. She was in active labor. It wasn't safe to transfer by EMS from this home birth. We safely did the delivery. This is my skills. I have the Breech Without Borders presentation. We do skills and drills monthly. We do the breech deliveries every 6 months to practice with a team. Like, that's how you show, if there's ever a question, a complaint of your skills and your standards, you're going to have bad outcomes. But it doesn't mean those bad outcomes have to occur because you weren't up with standards. You didn't have the knowledge and skills. You didn't have the resources in place. It was based on following the scope of every stage of your certification. Your international certification, if it's NARM, the national certification when it's CNMs and CMs, if it's the state local guidelines. There's quite a few states that still don't have regulations for CPMs and direct entry midwives and licensed midwives. All the states have CNM regulations. There's about 12, 14 states that have CM regulations. So you have to, if that state says CPMs can't practice because there's no licensure, only CNMs can practice, don't go there and try to practice. You try to change the laws, try to get the awareness. Don't try. It's so hard for me when midwives become underground. It's not serving our patients. It's not serving the greater midwifery to try to just be under the system. They will find you, and eventually you will be known and aware. So scope of practice in midwifery, we've talked about it many times. There's a lot of variations of scope of practice. Some midwives are full scope, meaning they do everything. They do primary care, they do GYN, they do infertility, they do preconception, they do birth, pregnancy, postpartum, they do newborn care the first month of life, they do postmenopausal care. Those are all things part of a certified nurse midwife, certified midwives national scope of practice. When you have full scope for a certified professional midwife, NARM is a little more restrictive. There's limited scope with gynecological services. There's no mention of primary care. There's still newborn, but most of what CPMs do is a narrowed scope of heavy obstetrics with a little bit of gynecological services. That's when they collaborate with the nurse midwives and the certified midwives to serve the more complex, higher situations that don't directly need a physician involved, more GYN systems, chronic medical conditions, primary care. Those are great resources. So I see a lot of communities where nurse midwives set up women's health clinics so they can collaborate with their colleagues. They don't want to be on birth call. They maybe don't want to have the liability risk of obstetrics part of their practice, but they will collaborate with the birth community, the birth center, home birth CPMs to be that resource to fill in the gaps of their scope of practice. And then the CNMs will have the next level up part of the system that they'll collaborate with the physicians in the bigger healthcare system for things that are outside of their scope. So it's really, really important for you to know your local area. And I stress and stress and stress, what are your state standards and how are they interpreted, not what all your colleagues are telling you how to practice. Those are completely, when you go to court and you're defending your scope of practice, saying this is what my friend told me to do, that's another midwife, and she was also practicing it inaccurately and out of scope, does not make it okay. So as far as midwives, most of what we know is pregnancy, birth, postpartum care. Prenatal care has to do with routine checkups. In the United States, it'll usually start between 8 to 12 weeks, but obviously if it's their first baby, they've had pre-existing medical conditions, frequent miscarriages, a lot of practices as soon as they're pregnant will start prenatal care at 4 to 6 weeks. So if they're normal and healthy, had babies before, it's typically 8 to 12 weeks gestation. And then it's every 4 weeks until 28 weeks gestation. Then it's every 2 weeks. And then at 36 weeks, that last month, it'll be weekly. And then usually most practices, once they get after their due date, it'll become every 3 to 5 days till they deliver. And then at 42 weeks, when they're post dates, they'll talk about the induction process as long as everything's been looking normal and healthy. In Europe, they do space it out a bit more. They do 4 to 6 weeks, 2 to 4 weeks, 1 to 2 weeks. And so when I had my private practice, I tend to keep my primips on the first-time mothers on that more US-based system, just because there's a little more risk and education and screenings and touch base points. But when they've had babies before, especially out of hospital practices, they've had home births, they've been with that midwife, they're normal and healthy, there's a lot of justification for stretching things out because you're not a super busy practice. They can easily set up a prenatal visit with you if all of a sudden they have a question, a concern, an issue, versus a lot of these bigger scale doctor's offices. They just can't see them quickly. They send them to triage. They can't do walk-in visits. If they don't schedule them every 4 weeks or if they schedule them in 6 weeks and all of a sudden there's an issue and they want to be seen 2 weeks early, there's probably not an opening in their office schedule to squeeze them in. So you have to think about both sides of the situation. It's not that, one practice is medicalized and one practice is negligent or too laid back or doesn't keep an eye on their patients. Like, we have to look at the culture of an area, we have to look at the individual situation, and we have to look at the system we're serving. Midwives in the community center are smaller base practices, more high quality, personalized. They get more time with them. They can easily squeeze them in to do an extra visit if they need to, versus these bigger systems. They just can't handle that adjustability and personalization. They just can't. So during labor and birth, there's so many variations of what this looks like across the United States and across the world. The home birth setting, you typically go to their house in active labor. If they have a doula, the doula will come to their house sooner and they will do the birth. They will stay for about 2 hours after delivery. If you have a birth center, the prenatal and the birth aspect is pretty similar to a home birth. They'll go to the birth center when they're in active labor, and then they will stay about 4 to 6 hours for the recovery, versus a home birth, they'll stay for about 2 hours to recover. So it's a little more extended. You don't want to start getting most of these birth centers, especially when there's state regulations, you don't want to be having them stay for 12 hours, 24 hours, 48 hours, because then you start getting into regulations of inpatient setting versus outpatient setting, and now you have to follow JACO and all the hospital standards, versus this is an outpatient birth center facility. From admission, quote unquote, to discharge, to the time that they're in active labor and they come to the birth center to by the time they leave, many times it's less than 24 hours. If you have states where there's no birth center regulations, these birth houses tend to push the envelope, and they'll have them stay for days and days. And as long as the medical system isn't going and complaining, but eventually it will happen. The other example I give is many of these pockets across the country with the Amish and the Mennonites, they have religious customized birth centers. In northern Indiana, they have a few birth centers that they stay for 2 days after the delivery so that the moms can recover and bond with that baby while the rest of their family supports their 8, 10, 12 other kids at home. So the state has approved of that extended stay because of those religious exemptions and that unique situation, not because they medically needed to be seen for 2 days, but it was part of the culture and to support the mother's recovery because of the larger families and the support networks they have. In the hospital setting, it varies greatly because if they're an induction, if they are not educated, they didn't have prenatal care, they may get a lot of triage visits, they may morphine sleep them, they may keep them as observation even in early labor if the moms are tired. But the goal is to, if you have a good labor and delivery unit with more physiological birth mindset and not high risk patients, they tend to ask them to be educated to come in during active labor, just like a home birth and a birth center delivery. And then you'll keep a close eye on them. They'll recover for 2 hours on the labor and delivery unit, and then they'll go to the postpartum unit. There's a few hospitals that are smaller community hospitals that have what's called LDRP, where the labor room and the postpartum delivery room, they're all one room, and then they just stay in that space the whole time. The equipment comes and goes. The delivery equipment, the newborn warmer, they come and go out of the room, versus the patient goes to the stages of the rooms that have that equipment. So every setup for midwives and how they practice and how they serve, like some midwives are completely independent in the home and the birth center setting, and in the hospital setting, they're part of a bigger network. They're closely working with physicians within the healthcare system, and they could be a private practice with an obstetrician and have privileges. They could be employed by the hospital, they could be clinic and call, they could be laborists doing 12-hour shifts on the unit, they could be strictly just triage, they could strictly just be teaching the obstetricians and the residents and the students. Like, there's so many variations of what the midwives can do during labor to support that process within our scope. For postpartum care, there is a variation of how to serve women. In the traditional hospital system, and a lot of the midwives that are employed by the hospital, they stay in the hospital for 2 days for a vaginal delivery, 3 days for a C-section, and they just call if they need something, and they'll do their routine 6-week postpartum visit. If they've had a C-section, they'll many times see an obstetrician or a midwife at 2 weeks to check on the incision, see how things are going. Sometimes they'll have a nurse do home visits and touch base with them. But our postpartum care, because of the insurance and the system setup that's in place, we do very minimal postpartum care here in the U.S. compared to other countries and cultures. It's really, really sad. When you have a home birth center midwife, we have the autonomy to do extra care, to more personalize it, to set it up more like they do in Europe and some of these other wonderful places. We come to their house for 2 hours after the delivery for a home birth, and then we go there at 24 hours, then we go there at day 3 to 5, then we do 2 weeks, then we do 6 weeks, and we can do more, we can do less based on their individual situation. We're working closely with the pediatricians, we're working closely with the lactation consultants, the postpartum doulas, the support groups, the mental health, if there's counseling, if there's social worker, there's support services that are needed. The birth center and the home have very similar postpartum recovery expectations. I say a birth center tends to have more of the nurses doing those postpartum home visits just because they have a higher volume, and the midwives have to be more on call for the birth center. But every situation is different. But all I can say is we need to have more touch base points for breastfeeding, for postpartum education, for mental health support of our moms and babies that the U.S. overall is not doing a good job at. I understand midwives tend to be a little better, but depending on which place you're practicing, if you have your own practice versus you're employed, you're still part of the bigger hospital healthcare system that does minimal postpartum recovery at this point. For newborn care, this is always fascinating to me because of every scope for a midwife has newborn care the first month of life, but the problem is nurse midwives in particularly get minimal training. They get signed off to do 5 newborn assessments. We get a semester of training for newborn education, but we're getting a hospital-based clinical training. We're following a postpartum nurse and going to the nursery and checking out a bunch of babies, listening to hearts and lungs. Right after the baby comes out, we'll do an assessment with the labor and delivery nurse on the baby and getting signed off. Very few nurse midwives are truly getting training in the first month of life. They're not doing home visits. They're not doing community-based care. They're not assessing jaundice past the first 24, 48 hours of when they're in the hospital. Most nurse midwives don't have hospital privileges for that aspect. The pediatricians have that. Community-based midwives are the experts when it comes to newborn care the first month of life, compared to the hospital-based nurses and nurse midwives and the training that they have. So there's great resources out there for the nurse midwives that want to go in the community setting. They can get during school clinical sites that are home birth center clinical sites. They can do Home Birth Academy. It's an amazing resource to help train in home birth standards and skills and drills and newborn care the first month of life. So there's a lot of amazing resources out there. It's not just educating and doing that immediate couple hours of as soon as baby comes out, the baby's the responsibility of the pediatrician. And I see that a lot with the newborn resuscitation. Like a lot of the hospital-based midwives, when they want to transition to community-based birth, they're used to a whole team and a call light and not being the lead and the having to be the expert in the newborn resuscitation. So there's certain skills and drills in the hospital setting and the roles and expectations of a midwife that are completely different than the community-based side. So with family planning and contraception, depending on what state you're in, so nurse midwives, pretty common, have full access to getting prescriptions, to getting family planning. A lot of CPMs, direct entry midwives, don't have prescription authority. They tend to do more breastfeeding, natural family planning, where they have to collaborate with a nurse midwife or a physician to get oral contraceptions, to get an IUD, to get more medical options of contraception. So a lot of home birth midwives, if their patients or clients they're serving don't want to interact with the bigger medical system, they tend to be diaphragms because you can order them online. You got to still have a prescription, but some of these places they'll have their doctors within the companies that will do the prescription with just a simple virtual consult or just filling out a form. Condoms, natural family planning, spermicides, those tend to be the more common options because of a combination of more natural-minded individuals tend to choose out-of-hospital births, but the barriers that midwives have in out-of-hospital setting to be able to offer all the options. So this is why we collaborate together so closely. I mean, not every form of birth control a midwife can do, like tubals and Essure and more of the permanent options, vasectomies. You have to collaborate with a physician. There's no midwife that does those aspects. So our job is counseling, education. If we can't offer that service within our scope, within our state regulations, our prescription rights, procedures for sterilization, we have to refer and collaborate with the appropriate services in the community. So risk assessment and referral, I don't think this gets enough credit when it comes to the scope of midwifery. We have to know our scope, know our standards. What can we independently take low risk healthy women in the home in the birth center setting? And we did a risk assessment. You did it at the beginning, you did it every prenatal visit, because if they risk out or there's some risk factors starting to occur, is this something I can independently manage? Is this something I have to collaborate with another colleague, a physician? Maybe this birth setting, maybe I can take care of this in the hospital setting, but I can't take care of this in the birth center home setting. You find on an ultrasound, the baby has some additional needs after delivery. The baby's fine inside mom, with pregnancy in utero, but when delivery occurs, there's going to be something wrong with the heart, the lungs, some of the organs that need additional support and NICU services that you just don't have in the home setting. So our job is constantly doing risk assessment throughout the pregnancy, especially during labor. You have to have really, really good skills of the right questions to ask, the right little subtle things to notice on our moms and our babies. Like, I've noticed as technology gets more and more part of maternity care, with especially with like ultrasounds, our hands are getting less and less skilled at Leopold's and presentation of babies. And as we're getting more and more dependent on a lab and a test to tell us things, we're getting less and less of our skills of, oh, you're looking a little more puffy, or the little subtle changes. She tells me she's fine, but she's actually getting abused. Like, we have to hone in our skills of that midwifery art that's been so ancient and wise, with our ears and our eyes and our touch, and our fingers are very powerful tools that give great assessments, that we need to give more credit and hone those skills more and more. So there's importance to keep boundaries between midwives and professional colleagues. Like, I think especially as birth workers, we become friends, we know each other, we really get into this next level of intimacy, and sometimes it can muddy that water of that relationship of like, are we friends? Like, there's been a bad outcome in a birth and we're just going to talk about it at the coffee place, we're going to talk about it wherever, or there's tension between us because I need an offer. This happened as a colleague, and now we're friends. And there's the boundary aspect of, you have to be able to have a life outside of midwifery for burnout, for professionalism. Like, we can be professional and nice and kind to each other at work, but we're not going to be BFFs. We're not going to, and then with our physician colleagues in our other system, we can have a nice, warm, professional market to go to and serve and collaborate with. But you want to be very careful, because it creates tensions and problems and conflicts of interest and biases with care when we're really good friends and we don't want to hurt each other's feelings because we're doing a peer review, we're doing competencies. It can sometimes cause a lot of muddied water and tension when there's much more personal connections with each other versus just professional. So we need to be able to work within our scope of practice. We need to know our policies and protocols. If you're employed at a hospital, make them, update them. If you have a private practice, you're ultimately, no one is going to check and balance you. You are in charge of making your scope, your standards, clear communication, SBAR, situation, background assessment, recommendations, your documentation, your policies, your protocol, your workflow. You are responsible for so many things as a midwife, and this is what makes us have great outcomes. You take baby steps. I think so many people, when they get out as new grads and they're starting their own practice, they get so overwhelmed with all these layers. And I always give examples with our consulting work. Rome wasn't built in a day. How do you handle an elephant? One bite at a time. Like, there's so many metaphors out there. You're just going to make a checklist of priorities. Safety always has to be resolved first. And then you slowly go down your list of like, okay, these are improving processes. Yes, this will work. It's a little clunky. It's a little outdated, but this is a safety issue. Like, there's gaps in care. There's lack of training. There's skills and drills being missed. We have to keep safety and high quality equipment's missing, equipment's expired. Those are things that are in the forefront. And then the other things, you make committees, you make teams. Like, I always think as midwives, especially when we do private practice, we think we have to do everything ourselves, and get a team around you. Get some amazing students, get doulas, get lactation consultants, get birth assistants, get childbirth educators, get lactation support resources, get an office manager, a receptionist, and you delegate projects, and you're the final stamp to review the things that have been asked of them. But this is thinking like a business. This is thinking like the next level, because we run out of time if we try to do everything ourselves. So definitely understand your scope in your area, your state, what is required of you, and what do you want to do. Just because a state's scope of practice says a midwife can do this, when you're getting employed, have clear expectations of your job description. And when you're running a private practice, you can pick and choose certain aspects of your scope. You don't have to do it all. So it's really, really important, just as a summary, as midwives, I want you guys to be able to support your communities, and I want midwifery to grow and thrive. When we have this Swiss cheese effect of gaps of care, midwives pushing their scope of practice, not following clearly their scope of practice, not keeping up with continuing education, not collaborating to the best of their ability with their community, this is where midwifery is really, really struggling.